Hello, everyone. We're going to give it a few minutes while folks are coming on, and we'll get started shortly. Thank you. Hello, everyone. We'll give it another minute or so while people are signing in, and then we'll get started. Thank you. Well, hello, everyone, and welcome to the Da Vinci Community Roundtable. We're a few minutes after the hour, so we'll go ahead and get started. My name is Denise St. Clair, and I'm going to be moderating for you today. We're very excited to um, get to cover the topic of navigating patient costs, transparency using the HL7 FHIR standards. And we have insights from an amazing panel, so we're really excited to share that with you today. But before we get started, we'll do some housekeeping. So first things first, on the next slide, we do all of our work in HL7 under the ANSI antitrust policy. So if there is something you would normally not bring up in public, might be mindful of noting that here today. Next slide. What we will cover today, first things first, we will have some updates from Casey Thompson on what Da Vinci is doing, so you can learn more about all things Da Vinci. And then we're going to have our patient cost transparency panel. Vanessa Candelora will lead things off with a presentation of where we are on the patient cost transparency use case. And then we have an all-star panel with Megan Meyer, Joel Hansen, Keith Lomery, and we will be hearing about their experiences as they're working to test and implement PCT. So we're very excited about that. First things first, a couple of things about how to engage in today's webinar. Your lines are muted so that we can support our recording quality, but we do strongly encourage you to ask questions. At the bottom of your screen, you'll see the Q&A opportunity, so please use the Q&A box to ask questions. In the chat, you'll see a lot of great information and links coming to Leslie, who we owe a giant thanks to for getting all this together for us today. But in order to communicate your questions, please use the Q&A box, and we will get to questions as we work through the session today. And at the end of the webinar, you will have a survey launched, and we strongly encourage you to please take a couple of minutes and complete that survey. It helps us a lot as we work to ensure that this content is as valuable and useful to you as possible. You can get the slides from today as well as the recording from today, everything about what is going on with DaVinci events and the DaVinci calendar at the link at the bottom of the slide, which will also be in um, the chat at some point if it isn't already. So that is a great place to get slides from today. Next slide. Our schedule for Community Roundtable. So we work to hold this generally every fourth Wednesday at 4 p.m. So our next scheduled Community Roundtable is March 25th at 4 p.m. Eastern. And again, stay tuned to the DaVinci listserv to learn more. And you will always be able to get registration details through the DaVinci calendar. And again, always access recordings and slides for current and previous roundtables from there as well. And lots going on in the community. I think there's 3 different major conferences this week, at least, maybe 4, where we know a lot of people are on their way to and from. But upcoming, DaVinci will be active and see you soon at HIMSS in Las Vegas, March 9th through the 12th. And there is also the AHIP Medicare, Medicaid, Duals, and Commercial Market Forum, which is in DC, March 23rd and 25th. HL7 has the US Realm Virtual Connectathon. First time there's one of those in conjunction with the International Working Group meeting. So the US Realm Virtual Connectathon is March 31st through April 2nd. And you will definitely be able to, you can get information about registration now, so definitely check that out. And then the working group meeting is in Rotterdam, so for those of you going, we're a little jealous, but there will be DaVinci there as well. And then finally, Dev Days is domestic this year, so that will be in Minneapolis, June 15th through the 18th, and registration is now open for Dev Days. So a ton going on. And we look forward to seeing you there and sharing with you what DaVinci is up to. Next slide. And speaking of what DaVinci is up to, I'm going to go ahead and pass things over to Casey Thompson to give you some program updates. Casey.
Thanks, Denise. Hi, everyone. I'm Casey Thompson. I'm a nurse informaticist and program coordinator for the DaVinci Project. I'm very happy to be here with you today and share these DaVinci updates. My slides are a little slow. There we go. First, let's do a quick review of our 2026 program priorities. This year, we will continue advancing our core functions with a strong emphasis on supporting our implementers, both directly and through our industry partners. We'll be putting significant effort into expanding our piloting activities, strengthening implementer engagement, and promoting shared learning across the community. These activities are essential to ensure real-world success. We also plan to explore new and improved methods for engaging stakeholders in the implementation guide development process. Alongside that, we hope to develop a rubric to help us assess investments in IG development and determine adoption readiness. This will give us a more structured way to prioritize and understand where our resources can make the biggest difference. Our work will continue to involve close coordination with our industry and federal partners, and it's important that we remain responsive to relevant policy issues as they arise. In addition, we want to continue elevating awareness of FHIR and collaborating to help the community better understand the value of FHIR and the meaningful progress all of you are driving through DaVinci implementation guide development and piloting. Now, there are resources listed at the bottom of this slide that you may also find useful. There's a link to our DaVinci in Action page where you can see who has implemented various DaVinci guides to date, our DaVinci LinkedIn page where we share all things DaVinci. We also have a link to our YouTube channel and a link to industry statements and updates. Now, this slide shows where our implementation guides currently sit in terms of maturity and STU phase, but I just want to call out a few quick updates since our January community roundtable. First, we've had a lot of movement on the burden reduction side. We've officially wrapped up public review and feedback reconciliation for several of our implementation guides, including HREX and our burden reduction guides, CRD, DTR, and PAS. So a big thank you to everyone in the community who took the time to review, attend our use case calls, comment, and contribute. Your input has been incredibly valuable. And with this phase now complete, these guides are moving toward publication very soon. We look to be bringing you those finalized versions very soon. Now, on the PDEC side, there's an STU update related to provider access expected in 2026, and details on this are being shared in our Friday use case calls. So I encourage you to attend that if you're interested. And risk adjustment is also planning a potential update in May. Now, there's a full list of all of our Da Vinci use case calls when they meet on the appendix of this slide deck. So I encourage you to take a look there and get involved where you can. You can also find all of our calls at the HL7 Conference Call Center calendar and add them directly to your calendar. Okay, that's all I have for updates. Now I'll turn it over to Vanessa to discuss patient cost transparency. Vanessa.
Casey, thank you so much. And what a great overview of all the exciting things going on across Da Vinci. Thank you for having me and our esteemed panel. I'm going to go through just a few slides. I won't take more than 15 minutes or 10 minutes. Just for some of you, I see a lot of familiar names out there, but some new ones, and expect this recording to go even further. So want to make sure people have a baseline overview of the Da Vinci patient cost transparency use case, some updates in case you haven't checked in with us in a while, and progress that we've made. So really excited to be here today. Thank you so much. So first and foremost, at the highest level, what this use case really started out as was how can we empower patients with price or cost transparency and information to get accurate information in advance of services to make more informed decisions, price or cost being one piece of the puzzle. And so thinking about, I attended the CMS Burden Reduction Conference virtually this morning, actually kind of all day, all morning. And, a really big theme of this was empowering patients with clear, actionable data. Right. And so that's really what this use case is about. And if we go to the next slide, you can see where the use case has really been paying attention to what's happening in the industry. There's been a lot of things in the news over the last year or so related to transparency, whether it's the transparency and coverage rule for payers, whether it's the hospital transparency rule for providers, or information about continuing regulation that's been coming out in parts around the No Surprises Act. And that's really where we're drilling in this implementation guide. So the No Surprises Act was part of the Consolidated Appropriations Act that went into place in 2022. And so it covered a lot of stuff. What most people know about the No Surprises Act is consumer protections from unexpected medical bills. In particular, if you're going to an in-network facility, but there's an out-of-network provider, you as a patient are protected from balance billing or getting a bill for those services when you didn't even know that that person was out of network. The piece that the Da Vinci patient cost transparency use case focuses on is around a requirement that states that providers share a good faith estimate based on what they know with a patient directly if that patient is not using their insurance, whether they choose to self-pay or are uninsured, or with a payer who the patient may have coverage with, and that payer then will create an advanced explanation of benefit. So think of that EOB that you get either electronically or in the mail today, but in advance, sort of detailing what your costs will be, what your patient responsibility will be. And so that's the part that we focused on here in Da Vinci. And we have a standard for trial use, STU2, that I'll give a timeline on in just a few minutes, that really outlines how that exchange of data can happen between providers and payers. Perfect segue, Casey. So this is our timeline. We started this work back in Q4 2020, and we quickly started with open community meetings and a lot of work happening across sort of defining what our use case will be. And so we pivoted pretty quickly to the No Surprises Act in 2021. And fast forward to now, we have our standard for trial use 2 version published as of last October. And we kicked off pilots just about a year ago. And that's really what we're going to focus on today and what I'm sure everyone is most excited to hear about. But I'll just say, it's been a long road. And for those of you that were with us on this use case, we are so grateful. We started off, in 2021, 2022 with 2-hour weekly meetings, really discussing a lot of the very challenging requirements that go into good faith estimates and advanced explanation of benefits. And those challenging requirements have not gone away, but we hope that the technology and the data standard to support those requirements will help reduce the burden of this effort to really make meaningful change in cost transparency for patients. Next slide, please. So this is our workflow. It starts out with step 1 being the patient either requests a GFE or schedules a service. And then the provider or providers put together their good faith estimates for the services that they intend to provide based on what the patient needs and submits that to the payer or gives it directly to the patient, as I mentioned. The payer then uses that information to apply coverage, apply contracted amounts, benefit balances, and make available an advanced explanation of benefit. There's a lot of variations. This, of course, is like a very simple picture, right? Sometimes there's only one provider involved, and you don't need that whole step 2 with coordinating between providers. Sometimes it goes directly to the patient and not to the payer. And then step 3 is really a simple make it available to the patient. So this picture kind of shows the most complex, but there's a lot of variations that the implementation guide can support. Next slide, please. So this is a new slide. Today is its debut. So congratulations, you're my guinea pigs for this slide. This is around that multi-provider step 2 from the last slide, good faith estimates. Again, this is an illustrative example, but really we're trying to show one way that separate billing providers can leverage a FHIR-enabled platform to help ease the burden of creating a good faith estimate that includes all the items and services for a patient's expected care, even if it includes multiple billing providers. So the common scenario is you're going in for a knee surgery, your facility has maybe an in-house surgeon or a surgeon that they partner with that bills separately, and then there's a separate anesthesiologist, there's a separate medical device that may be included on the facility invoice or not. And so that provider 1 is going to check to see if the patient is using their coverage and if it's active. They have to put all the information about the order, what procedure is going to happen, diagnosis codes that are relevant, revenue codes, all of that stuff, and go through the scheduling. And then once that happens, step 2, they trigger notifications to other providers to say, hey, we have this patient coming in, they need a good faith estimate. And we've enabled a way to do that via FHIR. And then step 3 is they need to create their own good faith estimate. And this coordination platform concept is really the system of choice of that provider that's coordinating all of this for the patient to get all that information put into one place. We call it a GFE packet across those different providers. Then that GFE packet can be delivered either to the patient or to the payer. And that could be the same system. Or it could be something that is a partner or built separately, or is a piece of technology that can support reducing the burden of that delivery. So, how have we made this real, right? Standards are only as good as if they're used. And so last April, we kicked off pilots with the goal of validating our Da Vinci Patient Cost Transparency FHIR implementation guide that supports No Surprises Act required good faith estimates and advanced explanation of benefits. And I should note that the regulation to enforce the advanced explanation of benefits has not come out yet. Just to be very clear, that's enforcement deferred. Along with the multiple providers, even for self-pay, is enforcement deferred. We are testing all of it to help make the technology real, and we have tested all of it. So the ability to coordinate across providers for GFE creation, the ability to communicate GFE from provider to payer, the ability to communicate an advanced explanation of benefit in advance of scheduled service, or upon request from a payer to a patient, and optionally back to that provider for continuity and parity of information and transparency and what that will look like for the patient for adherence to the medical plan, being a really key aspect of all of this. We have achieved a lot. So, as I just mentioned, we achieved all of that. We have also supported even looking at what that AEOB can look like from patient-facing apps who have kindly come to test with us and sort of demonstrate in a visual what that AEOB can look like. We've successfully executed cross-organization interoperable exchange, and I'm going to spend the next few slides kind of going through some of the key partners that have joined us in piloting and what they accomplished with a few screenshots for all of you. And then we've really gained a lot of real world insights. So, lessons learned, what do we recommend, right? We'll get to that when we get to the panel. But we've identified a lot of improvements and improved the guidance in our implementation guide, and also drilling into, non-happy path scenarios that are real world that can occur and how we can ensure that the standard supports them where it makes sense to. We've also tested a lot of just feasibility for industry-wide deployment and advancing even more insights, like from clinicians, for example, is a focus of ours in the next couple quarters, to really get even deeper and wider in how this can support different organizations. So really looking forward to that. I'll also just add that we have been sharing our lessons learned with rule makers to help inform their decision making as well. So this is a representative list of our pilot accomplishments, and I'm gonna just have this highlighted here, and then we will actually dive in this order, which is in order of workflow for those of you that think that way, over the next few slides. So next slide, please. So CareViso did test out and build out the provider workflow for a single provider, a single NPI. They were able to create and submit a good faith estimate via the FHIR operation GFE submit that we've defined in the guide, and retrieved and displayed the patient AOB back in their provider workflow. And that's the screenshot you're looking here today. I'd encourage you to check out their press release from last October where they highlight the value of this work. New Cure-All has really implemented the guide end to end. They provide, this is a screenshot of their provider workflow. They were able to demonstrate multiple NPI GFEs, so creating and submitting a GFE and retrieving a patient AEOB back in their provider system. And they've also built out the multi-provider GFE coordination to enable providers to contribute to one comprehensive GFE on a platform, including the routing and aggregating all that information, the FHIR resources available. And they've even contributed a GFE, so playing the role of a contributing provider to a different provider's platform, which was very great to learn from and have them test out. Next slide. So Kyruus Health, who is here today, we're very excited to hear from Keith, played the role of payer workflow. So they've received good faith estimates, both single and multiple NPIs via the GFE FHIR submit operation. And this is a screenshot of what that AEOB response looks like that they received back, or excuse me, provided back. So producing that AEOB packet with an AEOB for each of the GFEs. This is very think of like a nested ball, right? You've got the packet, then you've got the AEOBs, and then there's sort of a grouping of each, kind of claim pre-service available. So I put the picture from our guide in there to give you a sense of how it's sort of a nested packet and what different resource profiles go into this. But they've done an amazing job, and we're going to hear from them a little bit more. So we can move to the next slide. And this was a national payer that we will also hear from later today, who created AEOBs and made them available to patients via Patient Access API for authorized third parties, supporting patients' app of choice. They were able to map a system EOB and the data elements, that's what's shown here, to our FHIR AEOB. successfully, showing that the data that is available in an EOB, recognizing information upfront may be different, but the testing out of those FHIR resources was a big success. And that shows a test execution of 100% successful for a PCT compliant AEOB. And then we had the opportunity, as I mentioned, for two different organizations, FlexPA, being able to show how a patient could access their AEOB. So I really like this screenshot because it highlights, really supporting patients' understanding of their expected costs at a very high level, right? At the end of the day, a patient just wants to know, what will I owe? And what is the payer going to cover? And what else do I need to know, right? The service details, the procedure diagnosis, with consumer-friendly descriptions, which is not just a requirement from No Surprises Act, but something really important as we learn to empower and educate our patients. So this was great. And then the next one, thank you, Casey, was Be Well, also showing that patient access and how a patient can view an estimate within their workflow, their upcoming appointments workflow. So showing an even deeper assessment of the AEOB and all of those different data elements that can come from the payer, including benefit balances, how far am I towards reaching my deductible with this service included, this upcoming service included, excuse me. Next slide. And lastly, Lantana, who is a partner in leading this use case, has built out the entire reference implementation end-to-end workflow of the patient cost transparency implementation guide, and it is interoperable. Many of our piloters have used the Lantana system to test against as a first pass. So really exciting work. And if you're interested in a live demo, please reach out to us. With that, what's next? So we are continuing to build on our pilot efforts and really drive home implementer support changes via an implementer support page, which is now on Confluence, as well as continuing to advance our testing, our error and issue tracking, getting clinician feedback, expanding into varying scenarios, and building on that success with more depth and breadth. Using the HL7 events as sort of milestone dates. So we're looking forward to the HL7 US Realm Connectathon, March 31st and early April, as well as we hope the CMS HL7 Connectathon, usually happening annually in July. With that, I will welcome my panelists to come on, the most important part of this session, but hopefully that gave a good grounding for everyone. And so excited to have our panelists here today. So I see Keith and Megan. Joel, if you can come on camera too, that'd be great. Thank you. Excellent.
Wait,
Okay. So we'll give everyone a minute to introduce themselves. I think I was introduced by Casey, but I'm Vanessa Candelora with Point of Care Partners, and I'm a co-lead on the patient cost transparency use case. I have been since the start of it, ironically, and so it's been over 6 years. And I've worked really closely with the three of these folks over pilots the last year and just feel so grateful for them. So let me turn it over in order on the screen. So Megan Meyer, would you take a moment to introduce yourself, please?
sure. My name is Megan Meyer. I'm actually a cost transparency lead here on the product side for Aetna, CVS Health Company. I've had an amazing opportunity to be working in cost transparency for over 10 years and amazing opportunity to be working for Aetna CVS for the last 5 years, and really excited to share some details here today.
Awesome. Joel.
Everybody, I'm Joel Hansen. I'm the lead director for the interoperability team, and we're charged with delivering the FHIR-based APIs for CVS. So
Awesome.
Keith, I'll turn it over to you.
Okay, I'm Keith Lomery. I'm a vice president of platform and data at Kyruus Health, which is a RevSpring company. I worked in the price transparency space for definitely over 10 years. I should have calculated it before coming on. And we at RevSpring and at Kyruus Health, we're really focused on that end-to-end kind of patient engagement platform. And that can be going from how people search for care, including getting things like availability, being able to schedule appointments, and going all the way into being able to pay for it. So we really come at it as price transparency is so important to that overall kind of journey in being able to select care. And the breadth of what we do, we probably have every provider in the nation on one of our products. So we have a pretty complete view of the breadth of kind of what's going on in the provider community and are very excited about kind of this specific use case to really help with that price transparency process. So excited to be here today.
Excellent. Thank you all so much. We're so grateful to have you today. And so I am honored to moderate this panel. And I'll start out with sort of an overarching question. So, for your organization, what is the value of cost transparency and how does it align with your goals? Is it more than just a mandate? And what's the value of this work for patients as well? And we'll start with you, Megan.
Sure. Cost transparency is hugely important. Members being able to understand care and the cost of care is very much so what's important to us. So we think about it from when we have our digital tools, when we're doing communications, anywhere where we can have cost transparency available to our members is incredibly important to us. So we love to have it available in all of our different workflows. It's if I personify myself, right? My son had surgery earlier this year. And it was so important for me to understand what that was going to cost. I just need to know no matter what. And so that's hugely important. And we definitely want to make sure we can always have that information available to our members.
Awesome. And Keith, did you want to comment from Kyruus Health's perspective?
Yeah, I think we similar to Megan and to Aetna, view price transparency as just a foundational element of that patient journey. And for us, looking at it as people are coming in, and if you think about the overall flow that they go through, you may be seeking out a provider and knowing how much they're going to be charging you is just a critical piece of information. I don't think there's any other thing that you go and select care for or select like you don't go shopping for like a couch and be like, I don't really know what this couch is going to cost. I'm going to pick the couch and then find out later. And so for us, we're really trying to bring the healthcare space up to basically how every other component of society functions. And that's just so important for the patient or for the member to understand things. And for us is really at this stage about going beyond the mandates. I know many of us in this space have worked for a long time on supporting mandates like transparency and coverage and other things like that. But at this phase, where we really want to be focusing on is moving beyond some of the kind of check the box compliance things and going towards more of a can we give a patient that assurance that the price that they're seeing is actually the price that they're going to end up paying? Like our North Star would be much more about like, can we give them a quote that they could if they want to pay up front or they want to finance or they want to do something else, they can have some assurance that that is going to be what they end up paying. That's a very hard problem, I think, as many people here know, but it is what we really kind of aim for. And we think that that's kind of the core value to the member is we want to be able to give them that sense of assurance so that they can book an appointment, they can seek out care without having this unknown kind of fear of, oh man, am I going to be able to afford this? What happens if it's higher? And I think we all probably at some point are patients, so we all kind of understand the challenges with that currently. Like I think Megan had a good example. I have my own examples of you just kind of booking. You're like, well, here's an estimate. I have no idea if this is right. We'll find out at the end. And for me, as someone working in the space, I take it as a curiosity, but I absolutely see how challenging that can be as a consumer of healthcare, just not knowing what you're going to be paying.
Well said. Excellent points. And you make a lot of both of you made a lot of excellent points. I love the analogy to separate industries, whether it's buying a couch or the banking industry, right? That has really worked hard on transparent data exchange in a secure way. And I think healthcare can learn a lot from that. So that's really awesome. Moving on to our next question, the No Surprises Act has some really challenging requirements, right? And thinking about how it fits in with that bigger picture. How can the Da Vinci PCTIG help you accomplish the goals of expected No Surprises Act regulation and achieve that spirit of the law, really going beyond that regulation as you were describing, Keith? And this time we'll start with Joel.
Thanks, Vanessa. Yeah, it's a great question. And just to piggyback on Keith's comment about, taking these APIs beyond compliance, I really think that hit the nail on the head with the last question. And I think it's something that, Aetna, I see the Aetna leadership trying to do is, how do we really leverage these APIs we're building to, advance the member experience? I think patient cost transparency key is the key there to improving that experience. So with the No Surprises Act, I think it'll be similar to the CMS ruling around prior authorizations, where we saw them actually, shorten the response times and mandate, better, I guess, faster communications back and forth. And I think with future rulings, we can expect something similar in patient cost transparency. And really the IGs, I think, give us a way or a path forward to being able to deal with those shortened response times. I think the Da Vinci IGs in general, not just PCT, but when we talk about the other IGs like US Core, I think the goal is to make sure that the data is more complete, and they give us a way to do that. Improving the data accuracy so that when the data comes in first time around, it's right more often than it's not. And then, in turn reduces the back and forth that providers have to do to get the payers, and payers have to go back to providers. So I think, all of those things contribute to the IGs helping us being able to meet those stricter timelines.
It's excellent. Megan, was there anything you wanted to add? And then we'll go to Keith.
I think what's interesting about the IGs is it gives us those different avenues, those scalable solutions, right? There are, we have a lot of different workflows when we think about overall like ecosystem for Aetna as an example for different avenues of data, different ways we surface up data to members and providers and things like that. I think what has been, great when I think about the IGs is it is an option that gives us to look at that scalability as we look at, how that No Surprises Act would look.
Great.
Yeah, and I'll jump in. I think like if we just take one step back, I think Vanessa, you did a really good job of explaining kind of what all goes into creating that AEOB estimate. And I think what we look at there is it is an entire ecosystem problem. It's not something that just one entity can come in and solve. And when we look at price transparency historically, what you typically see is people trying to solve a solution in a vacuum. It's the as a payer, I am going to try my best to estimate out the how much a member is going to pay. And in that case, you can probably estimate out based on your fee schedule, based on a member's benefits and accumulators, fairly accurate to what you may be paying, but you aren't necessarily knowing what a provider plans to kind of end up rendering care for. And you're not going to necessarily get that complete view of what is everything that's happening in a care event. So you may be able to very accurately price out, here's how much the anesthesiologist for a knee repair costs, but that isn't really helpful to a patient or a member. Like, I want to know how much my overall knee repair is going to cost, not how much an individual item is. And is basically for your average consumer going to be impossible to kind of sum those things together. And when you take it on the health system side, they may be like, I know a lot about what care I plan to perform, and I'm really not very good at understanding where a member is in their benefits, how to apply any of those sort of things. And so each side has kind of historically tried to solve this more in a what can I do? And then I'm just going to wave away all of the things that I'm not good at. And I think what specifically the PCT kind of implementation guide and what we've been working on is kind of breaking this down into saying each element of the industry should own their specific component of this and giving us kind of that core standardized ways to talk amongst each other. And I think that like from a RevSpring side, we work across both sides. We work with health systems on price transparency. We work with payers on price transparency. And so we see kind of the entire flow of this. And I think this really allows us to tell everyone like, hey, here's your discrete little piece. Here's what you need to do within that piece. And then here's how you're going to interact with everyone else. And so from our standpoint, we think that this can really help accomplish the broader goal of solving kind of the actual patient problem of how do I get towards like a and not just a kind of hope and prayer of a estimate, but like here's an actual quote for how much we think it's going to cost you by breaking this down into those discrete units. And I think that really simplifies it for everyone about exactly what you need to solve. It doesn't mean it's easy, but it's definitely more manageable than it was kind of in prior iterations of this problem.
Excellent points, all of you. And this concept of accuracy, I think, has come up with all of you speaking at this point, and really getting to a specific estimate that's usable for a patient and accurate. And it's not easy, but I think that what you've really highlighted that I just want to call out is that, the challenge of working in these silos rather than sort of coming together and solving some of these problems together, trying to make it easier with this data exchange is what's going to bring some of that value. And if we can, what was discussed this morning at the CMS conference, kind of make some of that burden where it's necessary invisible to the patient, that's really where I think transparency can play a key role, and we have an opportunity here. So I love that you all highlighted that, and hopefully I summarized it accurately. So tell us about how you are leveraging FHIR along with your existing infrastructure and previous work to streamline implementation of PCT. What value has FHIR added to your workflow? How does past work you've done support this?
Do you want me to kick that one off, Vanessa?
Yeah, sorry. We'll go to
Okay.
Keith and then to you,
Oh, go to
Joel.
Keith. Okay, cool.
That's good.
Yeah.
Yeah, so for us, we definitely have leaned into FHIR over the years. So previously, you guys had that I forget what it's called, but basically the gas tank gauge of how mature different implementations guides were. It actually made me really pleased that the Plan Net one is now like in the mature status, because I remember attending Connectathons, I don't know, a number of years ago where we were kind of just iterating on the first versions of that one, and being able to kind of now have those sort of things as mature. We actually lean into that. We support many of our payer clients on a provider directory using PlanNet. We also really lean into that as kind of for any net new client implementation as kind of the default way that we want to be onboarding and exchanging provider data. So we find that FHIR is a good mechanism to kind of have a just kind of I think Joel, you mentioned kind of it's the almost kind of like I forget exactly how you said it, but kind of like a way to speed things up. And we really view it kind of similarly, if it's kind of a standardization foundational element for future innovation. And so when we can go to a client and be like, okay, are you already on FHIR? We can now just start exchanging data using this mechanism. And if you aren't, we really work with them about like, hey, this is a good way for us to work together. Let's kind of bring you along on the FHIR journey and leverage this. And so we find that very beneficial. And specifically, I think with the PCT project, one of the things that we have found is we've worked with our payer clients for many years on benefit data exchange. Megan and I have worked kind of in the trenches on this together for a number of years now. And we've always kind of had to create our own way of passing that data back and forth. Something like a 270, 271 EDI transaction just doesn't really get to the level of granularity that you need to do accurate price estimation. And so what we've always kind of said when we're working with a variety of the different players in the industry is we're like, look, we would love a robust standard to exchange this data on, but we don't have one, so we've kind of created our own in the interim. But we would love for Da Vinci or someone else to come along and really like define that standard. And so we're really pleased with this work because we think that both for AEOB, but also for a lot of other things, is actually giving us that standard way to exchange this data. So we're very excited about that. I think it's something that we're going to continue to lean into. I'm constantly telling my own team and our own organization, I'm like, you guys, this is really kind of a new fundamental way for us to work, for us to kind of scale this out. So let's really continue to invest in it. So for us, very passionate in general about FHIR and very, very excited about kind of specifically this PCT project and leveraging that as kind of a future way to standardize the exchange of a lot of information, but especially that benefit and accumulator information.
Love it. Go ahead, Joel.
Yeah, very, very cool. Yeah, it's good to hear that, Keith. We're on fire over here too. So and we've been on fire since the original patient access implementation. And I think the from an enterprise perspective, Aetna, they're totally dedicated to implementing these FHIR APIs, and like you mentioned, taking those beyond compliance. Um, I'll give a little plug. We do have a developer portal out there. It is developerportal.aetna.com that lists all of our FHIR APIs. And those include the patient access, the payer-to-payer, coming soon, provider access. We have our formulary provider directory, and our prior auth APIs are all there. There's also a sandbox environment. So if you want to test any of this, if you're watching this video, you're listening, or you're in this webinar, if you want to test any of this, you can go register an app and sign up. And it also provides a pathway to get to our production APIs as well. So again, developerportal.aetna.com. PCT will be added to that. So it's going to be a FHIR API once we have our GFE submit endpoints and the supporting, I guess, functionality stood up. It'll be integrated into that. So the registrants who have signed up for like provider access or prior auth, they will be able to get in there and subscribe to use PCT and then start creating apps for it. So that is our ultimate plan for patient cost transparency and how we're going to kind of integrate it into the infrastructure that we have. To go along with that, we have full testing and production support available through the dev portal. So if you need any help with registration or questions about using it, it's all on our dev portal.
Awesome. Thank you both so much. And I love the shout out to, the patient access API and some of the other Da Vinci guides, PlanNet included, and what I used to call the dial slide, Keith, but it's got a makeover. So but yeah, no, that's great to hear. And for anyone less familiar, that's the patient directory that Joel mentioned is also called PlanNet, and it's part of the PDEX, or the payer data exchange implementation guide. So if you're less familiar, definitely check those out, as they do serve a purpose in PCT as well, potentially, where they contain network information, right? And when I think about network information, I think about the requirement in the No Surprises Act for ensuring that a patient is aware that there may be an out-of-network provider as part of the estimate, with an option to have the way to identify where there may be in-network provider alternatives. And so I always think of that provider directory when we talk about that requirement. So great insights. Thank you. So next question is, what should organizations keep in mind? And Keith, you actually talked on this sort of ecosystem concept earlier, but it's not just one group involved, right? A whole mix of partners. And what should organizations keep in mind to be able to collaborate successfully? We'll start with you, Keith, and then go to Joel and Megan. Feel free to add any insights.
Yeah, I mean, I think the first thing that you want to keep in mind is that this isn't something that one organization is going to solve all on their own. And I think I deal with a lot of architects at a lot of organizations, and you can kind of see and anticipate someone looking at the implementation guide and be like, okay, how am I going to solve every step in here? And the key is really to understand what is the element that you're owning. And that's going to look different. If you are a health system, you're going to have some very specific responsibilities. If you're a health plan, you're going to have very specific responsibilities. And even within there, you may choose to own certain components, outsource certain components. You may be like, hey, the core pricing logic, that's something that we want to bake in, but getting good faith estimates from all of these different entities and the trusted handshake and all of that stuff, I'm not actually interested in doing that. I'm going to outsource that to my vendor. Or I may want to print and mail AOBs, and I'm going to outsource that to my print and mail shop. Like, really being kind of thoughtful about what are the core responsibilities that you need to own? What are the entities that someone else basically by default has to own, is I think the thing that is going to make it successful, and also make it a lot less overwhelming, because I think it can get overwhelming when you're trying to eat the elephant, if you will. So you have to really pay attention to, what do I need to do here? What does my organization and my team need to do? And that's kind of focus on that, knowing that this has kind of standardized the landscape significantly for all of those other actors so that we're not needing to worry as much about kind of everything else that everyone else is doing. So I think that's a lot of kind of what I would recommend, especially as you're maybe coming up to speed on this implementation guide, is really kind of focus in on almost kind of the like, who am I as a persona within this overall guide?
I love it. And I'll just put a plug in for the guide. We built it that way. So there's whole sections on if you're a health system or a provider, if you're a payer, if you're a patient representative, sort of where to focus throughout the guide. So love that that's how you're thinking about it. I think it's important. It can feel overwhelming. So great, great advice. Joel, any thoughts?
Yeah, I think the PCTIG and how it's arranged is just a really good example of why interoperability is important, right? Because you have all these parties, coming together. You have the convening provider, you have the provider system, you have the payer, and I think it really stresses the importance to have that set of standards defined in the guide, so that you're not having to build one-off things to handle every single instance of connectivity. And so that's the goal, right? Is if we all kind of follow the guides the best we can, we're going to be interoperable, and the data is going to be able to be more easily exchanged. And I think it really shows off, how we're kind of all dependent on one another, like you said, Keith, to follow the IGs, implement the standards, use common security, that type of methodology when standing up these APIs to meet our overall end goal. So I think that's really it, Vanessa.
Awesome. It's great. Very, very helpful. How has the Da Vinci PCT pilot process helped you advance this work, and what are some of your lessons learned? And we'll start with you, Megan, then Joel and Keith.
So I think what's been great about the pilot process is actually to look at the real world scenarios from a payer perspective as we go to the connectathons and as we work with the different industry partners to look at that to see how we can give feedback, how we can look at what a workflow may work like to make the standard work, if that makes sense. And so I think that that's been hugely helpful. And also just to actually be in that common space to talk about the different workflows and how the data moves back and forth. And then even, to some of the partners you referenced earlier that we've worked with, just to kind of have those different perspectives. As Keith and Joel both said, it's going to take different partners in different groups. And so coming together to be part of how we look at this IG to make this for options for implementation, I think has been hugely successful as part of that pilot process.
Yeah, no, I'll just add on to that. I think, Megan kind of nailed it there. Like, just having the IG going to the connectathons, it really helps us improve what's going into the IGs and understand what we have to put in the IGs to make them usable. I think prime example, right? The last connectathon, we added more, I think, of the, I guess, dollar amounts. So around the EOB to the AEOB, and then we were able to show that IG has places for those and the elements, or hey, we have to go in and add, another type or something like that for that. So I think that's where the collaboration comes in of the PCT implementers to test those different bits and pieces out and figure out what the gaps are, what works, what doesn't. And I think we'll get better as we take this to future connectathons and keep going forward.
Well said. Excellent.
Yeah, and I'll just add on, like I definitely agree with what both Megan and Joel have been saying. Is I think this pilot process has really kind of helped us understand and kind of map out the entire uh, ecosystem of this and how to solve it. I think for us kind of personally at Kyruus Health, one of the things that's also helped us with is for the past few years, and I know probably other people listening around this call have this similar experience, we've really been very focused on cost estimation around the transparency and coverage mandates. And that's a very kind of specific implementation that's very focused on items and services. And this really gave us an opportunity to kind of take a step back and think about this at kind of a broader scale. As we said, our North Star is really more towards like, how can we get to that price assurance that someone really knows what to expect? And this has really kind of solidified our view of kind of however you want to define it, but kind of a care event or what's that overall bundle for what someone's going to view. That's really where we need to be getting towards. And as much as other mandates may kind of help with getting kind of exposing core data, we really want to keep focus more on kind of like how can you price out that entire care event? And this really kind of helped us think through that on our own side, as well as just build some of the foundational tech that we needed to be able to price for kind of an entire bundle of codes and not just like a specific anesthesiologist. So that has been very beneficial for us and kind of really helped kind of as we're preparing our own roadmap, we're preparing our own kind of vision to really say like, yes, this is where we need to be getting to. Ideally, we get rule making and kind of everyone in the industry comes along with us. But even without that, we want to kind of continue to double down on this as kind of the direction that we go. So it's been very helpful in just kind of helping us think through our own strategy for how do we achieve that goal of price transparency and price assurance that we've been looking for.
Love it. Great insights, all of you. All right, last question. What are your next steps, both within your organization for implementing the PCTIG and sort of your longer term goals of your overall cost transparency strategy? And we'll start with you, Joel, and then Megan, then Keith.
All right, thanks. Yeah, we're currently working on the GFE submit endpoint. To be very specific, we hope to have that at the end of this quarter, and so that's kind of the next step in our implementation plan. And then once that's out there, we'll be able to add it to our dev portal. So everyone will be able to go out and sign up and be able to send us GFEs. I think the bigger goal is and ultimate goal is reducing provider burden, improving patient outcomes, and then definitely we have a focus on improving the member or patient experience that they have with Aetna, right? Can they come in and get the information that they need? I think Megan, you kind of hit it on the head. I think the patient's focus should be like on improving their health outcomes and getting the procedures and services they need, not really worry about tracking down all these estimates. So I think if PCT can help with that, I think that's the benefit right there in a nutshell.
Well said.
Yeah. And I think it's great, right? So when we look at, the PCT and that representation at the Connectathons and everything that, Jewel shared around that, and then also just in general around cost transparency, as the product lead for cost transparency in our digital experience, it is what I live and breathe every day. So as we look at this throughout our organization, it's everywhere. Members are at the heart of what we do, and how we can communicate cost transparency to them is hugely part of where we look to continue innovating. That's why, again, even partnering here through the pilots, what can we learn? How can we partner? How can we innovate? Cost transparency is hugely, hugely important. And, I know that Keith shared the couch example, but Vanessa, I always love when you do the car example. And, it really is, right? We can definitely personify that all the time and wanting to understand what things are going to cost. And so it's a huge part of how we look to, continue to innovate and offer that through all different experiences for our members.
And a car example is much better than a couch example. So I will fully say that my metaphor was weaker. But I think from our side, I think one of the kind of the million-dollar questions I don't know that anyone has a crystal ball on is what ends up happening with federal rulemaking here. Like that will definitely impact kind of what exactly happens next. But overall, I don't think it necessarily changes from our standpoint where we're focused in our overall North Star. While we'd like to kind of have the entire industry kind of aligned towards one thing and kind of moving forward with it, we are really looking back and moving forward with kind of what I've probably mentioned multiple times now, but kind of like the price assurance model of how do we continue to lay the groundwork for that, even if we don't have kind of federal rulemaking pushing everyone there. And from our standpoint, we do live on both sides of this industry. We work with health systems. And so we really view it with them is how do we do a better job of having them help kind of without having a massive amount of administrative burden, build out good faith estimates. Like, how do they build out across multiple providers so that they can do that efficiently and at scale? And we think that that can really help them. And then from there, how do we connect that into the really the specialization we have in working with payers, in modeling out their different types of benefits and accumulators? And so we kind of want to take both those tracks of how do we help the health system do their side? How do we help the payer do their side so that we can ultimately have that underlying foundation and that infrastructure so that we can give that patient confidence in the estimate that we're telling them is accurate to what they're going to be willing to pay. And so whether we get rulemaking or not, we definitely are still going to be focused on this. And our CEO always emphasizes that, like, it's really about the patient. And I think our view is if it's not useful information to the patient, if you're not giving them accurate information that they can make a care decision on, you're not really fulfilling that mission. So that's kind of where we are going to continue to be focused and continue to lay groundwork on kind of getting to that North Star.
Excellent. I love your concept of the North Star, Keith, and really making price assurance a reality for patients across America. It's so powerful of an image. And the car example image, if you are going to be at HIMSS, we hope that you'll join us. You can hear my car analogy, which is a good one, but transparently, we're talking about price transparency, and transparently, all analogies end at some point, right? You can poke holes in any of them. So let's not build it up too much. But we do hope that if you are going to be in Las Vegas for HIMSS in just a couple weeks, coming up fast, that you will come see Megan and I on stage Tuesday morning, mid-morning. So hopefully you'll join us. I think Leslie posted some of those links where you can access all of the Da Vinci HIMSS events throughout the conference in the chat earlier. But excellent comments. And I do just want to say one final thing, highlighting what Joel mentioned and Megan mentioned around, patient outcomes and really that sort of bigger picture goal as well. And, we often don't think about, cost and financials and patient outcomes are sort of this like clinical and cost, right? And how do those things fit together? And, I think that it's really important to recognize that some of the drivers for the need for transparency come from consumers or patients or members, whatever word we use, avoiding care due to potential medical costs or, becoming in financial debt due to unexpected medical costs. There's still a state action happening to try to help people not have their credit hurt by medical debt, things like that I saw yesterday morning. So it is really important that we recognize the impact that cost can have. I'm not saying it is for everyone. If you only have one provider in your town and you're in a rural place, you might not be shopping around for cost, right? But you may want to know the cost so that you can actively prepare for it and have an informed financial plan for it, as was mentioned earlier by one of our amazing panelists here. So just wanted to highlight that excellent connection to patient outcomes and make that a call out. Well, thank you all so much. We did have one question or a really comment that I did want to address, which was, we should go to next step. So thank you, Casey. Next slide. So how do you engage with us? You can join our public weekly calls. They're Wednesdays at 12 noon to 1 p.m. Eastern time. So bring your lunch. And join us on Wednesdays if you want to see how the sausage is made and be a part of developing the standard or really iterating on that standard for trial use 2 patient cost transparency IG. My co-lead Corey Spears from Lantana and I run that call, and we really appreciate insights from anyone that's able to join. We're working on implementer support and iterating on some of the feedback that we get from Connectathons and from our piloters like Keith, Megan, and Joel here, and also some work on the terminology to try to improve some of our code sets and value system, real technical geeky stuff. If you're into that, we'd love for you to come. Read the guide, pick it up, take a look at it, see how it can apply to your organization, how you play a role, as Keith was describing earlier, within the different pieces to really improve transparency overall. And pilot with us if you're ready and able. We are open for new piloters and always looking for new partners that want to come and test out their system with others. You can sign up for our listserv, our communications, and check out the conference call center, which is the source of truth for our calls. We will have a call next Wednesday, but we won't the following due to him. So that's where you find that information on the HL7 conference call center. Next slide, please. And these are all the links. So the implementation guide links, we have a hosted reference implementation. There are GitHub. This is open source code that's available to take a look at, test scripts to support the IG, and of course our FHIR chat community where you can come and talk to experts across FHIR, not just PCT, but all over the place. That's a really valuable resource for insights and information that I know developers are definitely using very often. So thank you. And now I will comment on one of the questions that I'm seeing, which is around CPT codes. And the part of CPT codes and the procedure codes are a big part of the patient cost transparency use case, understanding what procedures are coming. And most importantly, as mentioned in this question, the consumer-friendly descriptors as part of CPT standard files have been really helpful for some organizations to really give that plain language description to consumers or patients or members, as well as their care team to better understand what that service looks like, what goes into that. So great comment, Meryl. Thank you. Any other questions? We open it up for questions, Casey?
Yes, so folks, if you have questions, please use the Q&A feature at the bottom of the panel of the Zoom meeting. And I was going to say, as you were talking and as I was seeing Meryl's comment, obviously something that I know has been top of mind, and you've all mentioned it at several points throughout the panel, is user experience and remembering the patient. And I know that in the PCT calls, there are a lot of conversations about making sure that that estimate is usable to the patient. And so it was interesting, Meryl, to see your comment, because I remember us specifically talking about the CPT plain language descriptors and the value of that. But I was wondering if you could, especially for some of the developers, I know sometimes it's a little bit hard sometimes to see the difference between what is the IG doing and what will the output be for a patient, and sort of what is the IG's job versus what is the end user of that IG, or how those data after they've been processed through this can be used. So I was wondering if we might be able to talk a little bit about that distinction, because I know sometimes it can be a little overwhelming for new people coming in and sort of say how much of this is our responsibility, and sort of what are the options for making this the most usable for the end user.
Excellent question. I can comment from the IG perspective, and then I'm happy to hear from our panelists if they want to add anything. So just from a data standard perspective, so our implementation guide is not defining what a user interface looks like, right? So the screenshots from BeWell and FlexPa, some of those patient applications, that is not something we've defined how that will look or feel to the patient. That is really up to the implementers. What the implementation guide does define is the data elements that will be available in an advanced explanation of benefit or a good faith estimate that can be served up to a patient in a meaningful way. And they're part of profiles on FHIR resources that align with the standard FHIR resources that may be implemented in other ways. And so hopefully we're reducing that barrier for implementation to be able to make that leverageable for patients.
Yeah, and I'll just kind of chime in as well, thinking more about that, kind of taking the information that we receive in that AEOB packet and rendering that to a member or to a patient, I think is really, we definitely want to understand that there's different types of users out there. Some people may be hardcore power users. They want all of the information. They really want to see how everything's calculated. Other people are like, I'm having a MRI of my brain and I want to know what my MRI of my brain is going to cost, and I don't care about any of the details besides that I can trust this estimate. And so we think that that's really where I'm sure everyone will have kind of like their own opinion about like how to lay something out. But we think that like ultimately like a progressive disclosure, like keep things simple initially, but allow people to kind of go deeper if they want to be going deeper in there is a really solid approach. And it's definitely something we have experience iterating on in the past and something we'll continue to explore on with this. But we think that that is a super important thing because this AEOB approach can really, in the PCT implementation guide, it can give us really powerful data, but that doesn't mean that we don't easily overwhelm a consumer in the same way that probably we have in the past with other approaches. And so kind of our goal is how do you make something that's both accurate and useful to that end user? I think that's the kind of the Goldilocks piece that we're aiming for.
Well said, Keith.
Yeah, you guys nailed it. I don't really have anything to add except for, maybe we need to run that past and the patient, the member, and clinicians and whoever else, have need to review this before we start generating these things.
Yeah, and I also think I expect that with the different entities out there, people will try different things and we'll probably all learn together about, hey, these ones are really effective. These ones were good ideas, but ideally we kind of iterate the way most places do and kind of can help solve this problem in a very meaningful way.
I think the pilot groups have helped with that, iteration comment that you mentioned, Keith, right? That gives us the chance to be there in the moment, give it a try, kind of see how we connected with the industry partners, how the data, was coming through, and then how we could give that real-time feedback. So I definitely agree how that pilot has helped that process.
Awesome. Yeah, and we've learned a lot from piloters and my hats kind of blur a little bit, so this might be with my point of care partners hat on, sort of working with organizations, or it might be with my Da Vinci hat on. So I apologize, but we often hear that some of the top level information should be first and foremost, right? So what a patient owes, and what their insurance covers, and what the original charges were. And then the ability to, drill in deeper or double click on kind of as you were describing, all three of you actually, Keith especially started it, but thinking through like, what information is needed in there. And that's where a lot of the No Surprises Act requirements come in for information needed. Things like, is there a medical management technique, right? Is the sort of words they use, which really means just prior auth apply to this, or just step therapy apply to this, or what are those other things that may apply that could impact the cost? Out of network providers, being able to understand benefit balances and deductible or out of pocket limits, things like that that you may reach and what that looks like. Understanding the details of your diagnosis codes, your procedure codes, your all the information that you would need to say, whoa, this cost feels really high. What's the reason, right? And how can I talk to my care team about that, or shop for another provider that may be able to do it, with cost being one factor, right? I think most people aren't looking for, the cheapest they can go, right? I think cost is a factor, quality of a provider is a factor, location, languages. There's a lot of things that go into shopping. So, I didn't mean to open that can of worms in our last few minutes of the webinar, but do just want to call out that, I think the highest level information for the patient, and then the ability to have that deeper understanding so that patients can really be empowered with the information, right? If you get an estimate that's, $50, right, for something really big, you're probably not going to drill in much deeper, and you really would just want to know, okay, I need to save $50 to do this service. If you get something that's, $5,000, right, you might really want to understand what goes into that cost, right? Whether you understand all of the detailed information or not, if you have to Google half of it, right? But we want to inform and educate consumers to be able to understand what goes into their healthcare costs and really be better stewards of their healthcare dollar. So it's a really excellent points, lots of great points made. And Denise, thanks for the question.
No problem. And I think, again, if folks have questions, do be sure to use the Q&A button at the bottom of your panel. But I also think that these are all the wonderful reasons that it's really interesting. One, as a piloter, you get to be leading edge, right? So you get to really help define the future and understand what's going. So an opportunity for everyone to get engaged and get involved and shape that future. And the other really neat thing I think about PCT is that the way it's developed and set up, it does lend to integration with the patient access API. So to Vanessa's point that, there's all of this information depending on where you are as a patient in your journey that you may want to weigh, and having that sort of having price transparency be one piece of that puzzle is a neat thing. So it's also another way I think all of these standards and IGs coming together and supporting the patient to get that 360 view and help them really be informed and take action is wonderful. So a huge thank you for all of your work. But we can give it another minute or two and see if anyone has any additional questions. And in that minute or two, I will thank our panelists again for a really rich and wonderful discussion. And a huge thank you to you and everyone who supports this use case, because the team is doing really phenomenal work. So thank you all for your service. Well, I don't see any questions, so I think we can probably go ahead and give folks back some time today. Please do check out all of the very, very valuable links that have been shared in the chat. A huge thank you to Leslie for all of her work helping us get this program out to you today, and to Casey for the program updates. Again, we look forward to seeing you all at the many upcoming events. So thank you again. Have a wonderful rest of your day, and we will see you soon. Thank you, everyone.
Thank you so much.
Thank
Thank
you.
you all.